It is November 15th, 2021, and we are very fortunate tonight to have with us Dr. Joneigh Khaldun, who I won't tell you how many years I've known her, but I am very thankful that she was willing to join us tonight. And as I promised, I'm going to turn over to her almost immediately here to kind of introduce herself and tell you about who she is, what she was doing right before the pandemic, and where she is now. Well, there we go. Now she's with CVS. But Joneigh, over to you.
Thank you, Rebecca, so much for inviting me to the class this evening. Really excited to talk a little bit about the past couple of years. And excuse me, I've had some dental work recently, so my tongue and mouth is a little bit swollen and sore, but bear with me here. So over the past 6 weeks, actually 4 weeks, I'm now the Vice President and Chief Health Equity Officer for CVS Health. But before that, for a little more than 2 years, about 2.5 years, I was the Chief Medical Executive for the state of Michigan. And so public health, behavioral health, Medicaid, all those things actually were part of my umbrella for the state. And I was the Chief Public Health Advisor for COVID-19. And so it has certainly been a whirlwind the past 2 years when it comes to how the pandemic has played out. I'll also say I have the unique honor of also practicing emergency medicine as an ER doctor at Henry Ford Hospital in Detroit. So I think I certainly have a robust perspective, unfortunately, of some of the challenges of the pandemic and places where I think as a country, and quite frankly, as a global society, we really could improve. So let me talk a little bit. Is it not forwarding? Went too far up. There we go. All right. So let me talk a little bit about Michigan's curve. So this is Michigan's curve of COVID-19 confirmed and probable cases. And so early on in April of 2020, actually, Michigan was actually one of the hardest hit states from COVID-19. Most of the cases were concentrated in metropolitan Detroit, both the city of Detroit and also some of the suburb areas. And I'll never forget, just from a personal perspective, when I knew that this pandemic was going to be as severe as it has become. Of course, and this is what people often don't recognize, when we announced the first cases in Michigan, which was early March, we've been working, my epidemiology team, my other public health team leaders, we've been working on this for months. I mean, even when I was in December on my vacation, I started hearing about those first cases coming out of China. I remember saying to my husband, oh, okay, this is gonna be a thing. Let me dig into this when I get back from vacation in January. So we were actually working on this and planning for it for several weeks before the first cases became public. And I'll tell you, what I recall and when I knew this was going to be quite challenging is when my epidemiologist, who'd been on a national call, told me that the CDC was saying that only people who were severely ill or hospitalized or had recently traveled to certain areas were able to even get a test. And I immediately said to her, that can't be right. This is a respiratory illness. We know good and well that there are many people who are going to have mild illness and we're not going to detect that. Are we trying to stop this thing or are we just going to let it roll? And she said, that is what I was told. And so we strapped in and the pandemic happened essentially. And that is something that I will never forget. So again, Michigan was one of the hardest hit states early on. You can see our curve there. What's also important to note is we didn't have testing at all, really, for people across the entire country. So the point with that is our curve early in April was probably much higher than what you can see there, obviously. But we were able to bring our curve down and it became quite low actually towards the summer of last year. Then similar to across a lot of the country in the fall of 2020, we started seeing a significant surge. I'm very proud. We were able to put in place some very, I call them proactive measures to be able to bring our curves down in Michigan, whether it's approaching schools, indoor dining. Unfortunately, I think a lot of my guidance was accepted and taken by the governor, but it also created quite a political and sometimes violent response here in Michigan. And some of that was noted in the media across the country. But again, we were able to bring our curve down by being very targeted last fall. Unfortunately, in April, we saw another surge here in Michigan. And this was the B117, the alpha variant. Remember when that was the variant that we were most concerned about? And then we brought that curve down as well. But then, of course, as you all know, I do believe we're now in the midst of a fourth surge. The the curve is not quite as high. I think that's really because of vaccinations, but unfortunately, we're starting to see our hospitalizations creep up again. I think the real tragedy of this pandemic has been the way that particularly Black and Brown communities, communities of color, have been impacted by this pandemic. I'll tell you, it is certainly not a surprise. Michigan was actually one of the first states to actually publish, identify, and then publish our cases and deaths of COVID-19 by race and ethnicity. And just the way that actually happened is we were getting ready, we were posting our cases. In the beginning, it was a handful every week. It wasn't too many. I remember when we just had 12 cases, and that was a big deal. I remember those days. But when we were looking at publishing more broadly, we had a lot more cases. I asked my team, well, what are we saying when it comes to race and ethnicity? And what's interesting is we actually didn't have the data system set up to be able to track that. And so we had to do some work on the inside. That's another theme that I'll talk about is data systems are so outdated. People are faxing things. We couldn't get information from our labs. But we did some internal work. And then, like I said, we were one of the first states to actually release this data. We found a significant disparity. African Americans are about 14% of the population in Michigan. In the beginning, 32% of cases and 40% of deaths were in African Americans, which is just it's just a tragedy. And you can see the African Americans are that peach line there with some very targeted, data-driven actions. And quite frankly, I'd say leadership from our governor, Gretchen Whitmer. We were actually able to eliminate the Black-white disparity in COVID cases and deaths actually in 2020. We knew that progress was quite fragile because the reasons, which I'll get into, for those disparities go back centuries in this country. But my point is, you can actually, with intentionality and leadership and being bold, you can actually do something about disparities, and that's something I'm actually quite proud of in my work in Michigan. So I do want to talk about, because I think it's important, and this is from the CDC, people of color are generally more likely to be infected by or be made severely ill by COVID-19. And I'm not going to read all the numbers on your slide, but at least twice as likely to get infected and certainly to die when you look at African Americans and Hispanics. So really something that's just a tragedy. And I think it's important when we think about pandemic response, and I heard Rebecca say, what you're going to be doing in the next pandemic, I hope that, you know, there are things we can do today that would prevent these things from happening. I think when we think about disparities, we have to not assume that they're always going to exist and that they're just something that's, again, just a way of life. They are actually something that we can do something about. So some of you, this is not my slide. Some of you may have seen this many times before, but I like it, so I keep using it. You may know that most of what really contributes to someone's health is determined by what happens outside of a hospital or clinic or doctor's walls. So healthcare is totally important. We want people to have access to good doctors and quality care, but a lot of it has to do with health behaviors. And those health behaviors, sometimes diet, exercise, alcohol, tobacco use, a lot of that is has to do with the stressors and the access that you have in your own personal life. The physical environment obviously is very important and impactful when we talk about pollution and the fact that in a lot of cities where the dump is and where the industrial plants are is often where the poorest people in a city, and unfortunately the people of color, live. That also has everything to do with someone's ability to be healthy. And then education, job status, all those socioeconomic factors that you see up there. And the challenge, and I'll talk about it as it relates to COVID, is that unfortunately, because of structures and racism, quite frankly, in this country, we see that Black and Brown communities, unfortunately, are more likely to have fewer resources, no resources sometimes, and be more likely to be infected and therefore die in a pandemic. And it's simply just a tragedy and something that I focused on throughout my pandemic response efforts. So I want to talk a little more about that because I do think it's really important. When you talk about COVID-19 and exposure, right? So let's go back to the beginning or even now. Uh, People in the beginning, we were doing shutdowns, right? Everyone was staying at home. There are many folks who, because of their line of work, whether it's meat packing facilities where a large Hispanic population works, whether it's bus drivers, people who may be working on the front lines in grocery stores, those individuals did not have an opportunity to say, I'm going to just work from home and be safe from this virus. And that's what people were telling folks to do, right? That's a challenge. We also talk about housing conditions. Early on, I remember looking at the CDC, looking for guidance documents. There was always like hundreds of guidance, thousands now, guidance documents on the CDC website. But if you looked at the one about isolation, it said, okay, if you get infected, make sure you use a separate bathroom in your house. Now, I feel privileged. I do have more than one bathroom in my home, but unfortunately, a lot of people, people who are more likely to live in poverty don't have that option. And so inherently, by what we were telling people to do to be safer and the way our society has been structured, some people were more able to do that than others. Talk about inadequate or no access to medical resources. If you talk about testing, early on, a lot of folks weren't able to get access to testing. If you talk about vaccines, in the beginning, a lot of doctors were first in line. States had an opportunity to determine who would get a vaccine when, but we had guidance at the federal level, but really states could determine where the vaccines would go. And oftentimes there were MDs, obviously people who are more privileged in society who had access to those vaccines, or because there was such an emphasis on speed, which I don't disagree with, but we put our vaccines in a lot of these mass vaccination clinic sites where people had to get to them. And so unfortunately, if you don't have a car, if you're not able to drive to or find someone to get to that vaccination site, or even sometimes you needed to make an appointment, you had to get online. You don't have access, you don't have a computer or access to the internet, you are going to be left behind when it comes to having access to vaccines. And that is what we saw, unfortunately, across the country. Monoclonal antibody therapy, which I think we all know about now, but in the very beginning, when those were it was a very limited supply, limited resource, we had to determine where that was going to go. And we were very intentional in Michigan. Again, that's something that I pretty much mandated of my team to think about things like social vulnerability index and how we think about where our marginalized communities live. How do we think about that when we're resourcing important things like vaccines and therapeutics? I already spoke a little bit about the data infrastructure. There are some health departments, you're still using fax machines. Even to this day, they're still using fax machines, some of them, but that's the norm. and if something is faxed, God forbid it's faxed on a Saturday or Sunday, someone's not going to get the information on Monday. So we have a pandemic where, of course, we want to know who's being exposed, who their contacts are. The media, which is a whole nother aspect of public health leadership. The media wanted to know if you didn't have the information, they thought you were being deceitful and didn't want to share. The fact of the matter is, we didn't have the information and we didn't have the structures in place to have that information. And so, excuse me. And so we couldn't actually target our efforts when it comes to this response in a way that would have been equitable. And then finally, just because of the history in this country, there's a lot of mistrust. There's a lot of mistrust, especially in Black and Brown communities, of the healthcare system overall. And so that absolutely contributed to a slowed vaccination effort and hindered our pandemic response. So something I'm very proud of, I spoke about this already, was our governor's leadership. We identified those disparities. The governor stood up and was, I think, one of the first states, at least, to declare racism as a public health crisis. But that's not sufficient. It's good that you have leadership that recognizes it, but you really need to follow up with resources and policies and programs. And that's what we did in Michigan. We actually, when we recognized that we had Southeast Michigan, primarily in our Black and Brown communities, more deeply impacted in the beginning, we actually put millions of dollars into a targeted media messaging campaign, making sure that the messages resonated with people on the ground. We utilize a lot of community-based leaders, faith-based leaders, to actually get the message out about the importance of getting a test or isolating and protecting yourself. We distributed free masks, free tests. We actually provided funding to community-based organizations. And then from a policy perspective, we had an eviction moratorium. We expanded our SNAP benefits, food benefits for people in the state. We actually did mandate race and ethnicity reporting for our providers who were doing that testing. And then we also were able to move forward with implicit bias training for every doctor. Any actual health professional in the state of Michigan now has to undergo implicit bias training in order to get their license or renew it. So these were, I think, the ways that we specifically were actually able to bring back that curve down that I showed you earlier in the spring of 2020. So let me also talk a little bit about, just when I look back over the past 2 years, what was really important when it came to our pandemic response. And I'll tell you, every day was, it was interesting for me. I actually, I presented at, I think, over 100 press conferences with my governor. Some of you may have seen headlines of some protests in downtown Lansing, Michigan's capital, with people holding up Confederate flags and people holding guns and all of that. I actually had to walk through that on my feet for about 8 blocks through that, which was an experience that I will never forget. So that was kind of the public facing aspect of the role, but also internally, the operations, like what are all the pieces that go into a pandemic response? Any given day, I'd sometimes be briefing my governor, I'd be talking to my epidemiology team, be working with my communications team on our website and data. Medicaid, I didn't talk about this much, but what were we doing with Medicaid as far as what we were covering, allowing people to get things virtual. So virtual visits, we actually started covering in Medicaid. So there are a lot of just policy approaches that we really had to think about in my role. But every day was, it was very different, and most days were quite stressful. I'll say that. But communication, I think, and this is be first, be right, be credible. That's not my saying. That's just CDC and others' basic crisis response. The thing that's been challenging about COVID communication is we haven't known. There's no textbook. We were learning about the virus as we were trying to fight it. And unfortunately, something that I realize is that while as a physician, I am very comfortable actually with knowing that sometimes I just don't know. I know that new data and science will come out, then we'll pivot our strategies, we'll pivot how we treat people with for different diseases. But we didn't know that. And so it was very important, it has been and continues to be very important for COVID communication to say what you know, try to say it up front, but also say what you don't know and say that things may change. And I think early on, probably on a national level, we probably didn't do a good job of that. So when things changed and we had to pivot, people thought, oh my gosh, none of you know what you're talking about. And it actually created more distrust, I think, unfortunately, among some people in the public. Data and analytics, there was so much we had to do there with building a data infrastructure. Oh my gosh, in the beginning, working with, I would have chairs of all the emergency departments calling me upset because they couldn't figure out how to fill out the form, and the form was too long in order to get their patient a test. And then I was dealing with my lab on the back end, who literally, we had a warehouse full of FedEx shipped tests, and we were trying to open up the boxes and take pieces of paper out and determine based on whatever someone did or didn't write on the form, who would get that test run first. I mean, this is the reality of how, quite frankly, ill prepared our entire public health system, I think, was and didn't have to be when it comes to responding to a pandemic. So data analytics, interoperability between different systems, why we're still using paper in this day and age, I don't know, but that absolutely was something that we had to address and was just key front and center in our response. I already talked a little bit about testing vaccines and therapeutics, but there was a lot of just operational thought as far as where we would place these tests and vaccines. We actually did use the social vulnerability index, and I got a lot of heat in Michigan because in the beginning there were only a limited number of vaccines that were delegated, allocated, I should say, to the states. And so literally I would have my 100,000 vaccines, and you'd have every health department, every health system, every doctor wanted them. And it didn't make sense to give 2 or 3 vaccines to everyone. So we really had to make some really tough decisions about who would get a vaccine. I actually said, we're going to pull some off the top. So let's just say there were 100,000. I'd pull off 30,000 and say, nope, let's have a strategy where we're going to work in communities. So we actually almost put out an RFP for community-based organizations. If you were partnering, if you were located in a place that had more marginalized communities, if you showed that you had a good partnership, we actually would allocate vaccines into those communities, and importantly, have to be in those neighborhoods, not a mass vaccine clinic somewhere where someone has to drive 30 minutes, but in those communities. And that's how, when we did that, we actually saw our vaccination rates in those communities go up. So it's a lot about access, which was really important. Contact tracing, as you all know, critical. I won't go into that too much, but it's still a real challenge. People are not answering their phones. People don't want to tell you who their contacts are. We try to use, many of you probably have access to apps, that exposure apps, but really the exposure app really can't take the place of a human being talking to you about who you may have been in contact with. And so we really had to, and if people don't even get the exposure app in the first place, it's really not useful. And then healthcare capacity. My goodness, I'll never forget working in the ER early on in the pandemic, maybe March of 2020, and going and trying to find, I always wash my hands before and after every patient visit. And then all of the hand sanitizers were empty. And I said, oh my gosh, what is happening? And then I couldn't get a mask. And what do you mean save my N95? The concept of me needing to use an N95 for multiple ER shifts is just, that's something that we never thought we'd have to do. And so a lot of what we did, that was my ER experience as a physician, but a lot of what we did at the state level was work on healthcare capacity, being able to distribute very limited resources, looking at infrastructure plans, crisis standards of care, which I won't get into, but we did a lot of that work with our hospitals. And early on in the beginning, it was challenging. We had in Southeast Michigan, our hospitals that were at capacity. We were looking at standing up alternate care facilities, literally a convention center with curtains to take care of patients. We had places in the rest of the state where they weren't even seeing really very many cases yet, and they were not willing to accept transfer patients from Southeast Michigan. And so there was a lot of ethical and hard conversations that we had about, are we one state? Do you support your brother down the street? But very, very difficult conversations. If you get time here, I think I'm doing all right. One of the other things I really was just honored to be a part of was President Biden's White House COVID-19 Health Equity Task Force, which really was charged with setting a vision and recommendations on how to address the current pandemic and inequities that we saw, but also future pandemics. And I would argue not just pandemic response, but really what we see as far as all of the health inequities and disparities that exist and what we can do about them. So just last week, Very excited that the report was presented to the president. Kudos to all of my colleagues and so many staff members at HHS, the chair, Dr. Marcella Nunez-Smith, who is my new hero, who really helped to drive these forward and set priorities and a vision. So I think importantly, and I'll just briefly touch on the priorities, but investing in community-led solutions, it's so important that when I've worked in Baltimore, I didn't say this, but I was the chief medical officer in Baltimore. I was the Detroit Health Department director. It's one thing to have a title and have an office and do all the research and think that you know exactly what a community needs. It's so important that when we have these roles, we actually work with the community and don't place ourselves in the community and think that we know what they need. I think that's a good way to go wrong, to not have or understand the appropriate solutions. And quite frankly, you often won't get buy-in for whatever you're trying to do as well. So investing in community is so critical. I already touched on data, increasing accountability. I'll tell you, when CMS tells hospitals what to do and how they're going to get paid, they fall in line and they do it. And so really holding folks at the highest level accountable. If data systems had to be built a certain way, if we had to get more granular when it comes to racial and ethnic data, and I'm talking a lot about that, but the disabled community, those who don't speak English as their primary language, there's so many groups of people who were have historically been marginalized and who had disparate outcomes when it comes to COVID-19 and other health concerns. So I think really enforcing data so we can understand, collect the data, and then understand and target our solutions. Workforce representation is so important. And then again, that high level leadership at the top to actually implement the recommendation. So the report is out. I didn't want to show you all, there's like hundreds of recommendations. I don't know, Rebecca, if you had to read them. But there's a lot. I am quite proud of the work. And even if we did half of them fully implemented, I think the country would be in a better place. And again, just so grateful for that opportunity. So what's next for me? I think one thing I always say, and this was before I came into my new role in the private sector, the work of public health is not just about the work of governmental public health agencies. Absolutely, there are things in code that are law as far as what the federal, state, and local health departments have to do. But I think what we've seen with COVID is that there's not just one entity that has to step up to contribute to assuring a community can be healthy. And when we don't invest, and unfortunately we always underinvest in governmental public health, we really are not setting ourselves up for success. So whether it's a hospital system, I think all employers and businesses now know that they have a role to play, excuse me, in keeping communities healthy. The media, my gosh, messaging has been so critical, and getting the message right and on point has been so important. Academia, I didn't talk a lot about this, but we had very strong partnerships with several of our universities in Michigan. And that's how we were actually able to fill in some of the gaps where we didn't have certain resources at the state governmental level. And so this is what I've been doing for the past month. And I always get a little shy. I was debating whether I was going to add this slide because I'm like a secret introvert, even though I've done over 100 press conferences with my governor. But I'll tell you, the work of the past 2 years has just been the honor of my life. When I got into that role in the state, I had no idea that this was going to be coming. I wasn't even sure I wanted to take the job, quite frankly, when I took it back in 2019. But I'm just so honored. I think to say that I helped save tens of thousands of lives, which is what the data models tell us from our our work, and the governor, that's Governor Gretchen Whitmer right there, and Lieutenant Governor Garland Gilchrist, one of my good friends there. I mean, it's just been an honor. And so for those of you who are considering work in public health, uh, government, but also in other places, I think it's truly something you should strongly consider. I don't regret a single moment. But now I'm at CVS Health, and so why did I come to CVS Health? CVS Health is a Fortune 4 company that owns a health insurance company, Aetna, and also Caremark. And obviously, everyone always knows about the pharmacies and minute clinics and health hubs. But I say all that to say, I think there's such an awesome opportunity uh, for CVS Health to really play an important role in how the community thinks about health and how we drive health across the entire country. And so I found it to be a really just incredible opportunity. CVS Health has actually done the majority of testing that's been done in a retail setting across the country. And quite frankly, we wouldn't have been able to get ahead when it comes to testing across the country if they had not stepped in, and as have others, of course. But I think there's just such an awesome opportunity in the private sector as well to do great work. And so I'll stop there. I'm happy to answer any questions about my experience, but thank you. Thank you for having me in class.
Joneigh, thank you so much for being with us today. Thank you for everything that you've done. I for one enjoyed your watch, even if you say you're a secret introvert, like you were amazing to watch in all the press conferences, and thankful for the leadership that you've shown over the past now 22 months. So thank you, and thank you for being with us today.